Good morning. My name is Julia Challinor. I'm a pediatric oncology nurse from California. My work over the last 25 years has been exclusively in countries with limited resources, from Latin America to Africa and in Asia, specifically in India. I'm here with my colleague, Annie Young, to discuss our special issue on the documentation of the impact of COVID on oncology nurses across approximately 15 countries in all WHO regions in the mid-2020, when the COVID was first hitting hard across the world. Annie?
Hi, my name's Annie Young, and I'm a adult cancer nurse by background, and I'm semi-retired and working part-time at Warwick Medical School. But more and more, I'm getting into global cancer care, global health, but mostly global cancer care. And it's a delight to be on here and to tell you about the series, because it covers all the WHO regions and it is focused in low and middle income countries. Thanks, Julia.
So we thought we'd open up and talk about, from my perspective, because I'm a pediatric oncology nurse, the early reports that came in for us really came from Italy and the Lombardy region. And the publication was made for documenting the evidence from February to mid-April 2020, comparing it to the year before. And they saw a significant drop, 55% drop in the number of children who came in newly diagnosed with cancer. This really was concerning. In addition to that was the fact that they tested 360 children that did come in, were newly diagnosed with cancer for COVID. Only 21 were found to be positive. 15 of the 21 were on therapy and had to have modifications made to their treatment. So those were the early facts that we were getting as far as treatment of children with cancer. However, in many settings, and we noticed this in our series, families were reluctant to come to the hospital for fear of contagion and worries about the hospitals being overwhelmed and with patients with COVID. In the US, the media showed pictures and stories about mobile morgues and field hospitals being set up to manage overflow, for example, in New York City. Nevertheless, we heard from colleagues in the countries with limited resources of families of children deliberately going to the hospital if they could find transportation despite lockdowns, because they knew they could secure food and housing supported by local NGOs. And in fact, we do have a part of the series that discusses the role of NGOs who had to pivot to adapt to the lockdowns and the restrictions that were in place and still support these families of children of cancer who were actually on active treatment. Pediatric oncology nurses went on blogs, for example, in my country at the US, the APHON, Association of Pediatric Hematology Oncology Nurses, because we were looking for guidelines to share and policies in hospitals in early days, for example, for PPE use, visitor policies, algorithms for when to test or to admit symptomatic children with fever and neutropenia were all in flux, and no one knew what best practices were. Another survey of 311 healthcare professionals at 213 institutions across 79 countries in WHO showed that few centers closed entirely for some days, but 50% reported a decrease in newly diagnosed pediatric cancer care centers. And I think that really is what we started to see. The patients were not coming, they were not being screened, they were not being diagnosed, and that was concerning for us because, of course, we would rather see somebody early diagnosed than a late stage diagnosis because the treatment is so much harder. Annie, what was it like for the adult oncology side?
So very similar, Julia, and as time went on, we got lots more data on that, really. But thinking about low and middle income countries, the European Cancer Organization, ECO, have done a big, it's kind of, they want to help, and they've got seven point plan for healthcare professionals to help with it's time to act and do something about the missing cancer. So that's what we're worried about just now. So it's very similar. The screening was shut down. This is low and middle income countries as well. Very similar in high income countries, as you say. Screening shut down and prevention just went to pot as well. So just very similar to paediatric oncology. So I would have a look at the ECO website, the Time to Act, because we're saying we have to act now to do something about the backlog, and it's not scaremongering. It's we have to do something. It's all over the papers every day in the UK, and we know from our nurses telling us, their voices telling us that happened in Lebanon, for example, as well. In this series, they talk about that, and that was the early days, and now it's rising and rising.
I think one thing we really learned from the series was that COVID became the great equalizer. Suddenly, countries with high income that were used to having PPE whenever we needed it, we ran short. We were experiencing circumstances our colleagues in lower and middle income countries face every day. And this was a real wake-up call for us. And I think that for oncology patients, it was particularly scary because they were used to receiving care that's extremely intense. They come to the hospital. For us, our children stay in the hospital for weeks on end, and suddenly they couldn't have both mom and dad there, or grandma couldn't come. Visitors were restricted. I think this really caused a lot of suffering within the family. When there was a patient who died, they couldn't hold funerals. They couldn't have the traditional cultural observation and rituals they would have gone through that are very comforting for families. What did you think the psychological impact was for patients when you were thinking about the early, mid 2020 and what we saw in the papers that we have in the series?
So the psychological impact. So I called it triple jeopardy for the articles we heard. We got through the voice of the nurses that we got through our series, because it was low and middle income countries, the economic and social deprivation and situation, but they also had the fear, as you said, Julia, of the contagion, the fear of the virus, but their fear of the cancer and the cancer progression, or the fear of not getting treatment. You've said all these things as well for the kids. So there are multiple studies showing that the increase in distress in adults and children during COVID-19, but we have to remember that this increase is not universal. So there are some studies that show that there was no increase in distress as well, but the majority showed this huge increase in psychological distress. So just following on in paediatric oncology from Julia, she found a nice review that researchers in Iran found that the children during COVID were restless, lonely, and bored due to the social isolation and the restrictions and support, and sometimes only one parent was allowed to visit, and so they didn't have, for example, their fathers with them. But the youngsters, the young adults, felt they were exposed to an enormous and unknown threat as well. So the parents, they felt that they were there was a huge lack of emotional support. This emotion, rather than the physical, or the physical as well as the emotion, was overwhelming, but they weren't getting any emotional support because all the nurses the oncology nurses were dealing with was with the COVID restrictions, really. And they felt that some of the care of their kids was getting sidelined, and that's a lovely review of paediatric oncology from the family point of view from Iran. But to move on to adults, there has been a very recent systematic review by Moni Mohamed et al. In 2021. And they looked at the most common, they looked at the causes of the psychological distress rather than saying there was increased psychological distress. And again, it was the fear of COVID-19, the fear of disease progression, the disruption, as you talked about, Julia, of the oncology services. And this depended on the cancer stage. So adults with a later cancer stage had more distress. And they found that they were, and also they were felt at increased risk during treatment because of their immunocompromised situation. So these were the four big, some of the main causes of the increase in psychological distress. But what they did, what they felt was that this was an expected reaction to COVID-19, to a pandemic. This was an expected reaction, and that we have to normalize it. So this is throughout the world, really. So we all felt it, but it was so much worse for those adults with cancer. The adults with cancer felt that the process and the system was so confusing that some of them had to stop, that some of them felt they had to discontinue their treatment, which was awful. So it really did endanger their long-term health and prognosis. So really to find solutions to that was hard for the healthcare professionals, which I'll go on to, but also hard for the patients. So we heard about telehealth, didn't we? So some of the authors told us about telehealth, but they found that telehealth was not the panacea for all. So this systematic review says that telehealth in some instances, when they were talking to the patients, actually increased their distress. And we know about the digital divide and some folk can't have no networks and things, but telehealth is a solution that's mentioned a lot, but it doesn't work in all circumstances, especially in low and middle income countries. So psychological morbidity was huge, but our authors tell us that these are fragile health systems at best. And the scarce resources and the workforce, you've already said there's, the workforce is reduced anyway, is not there in normal times, never mind during a pandemic. And the nurses were scared, and I'll come on to that as well. So we found that the patients and their families experienced really high distress anxiety because of the care system and the care confusion really at that time. So it wasn't just the patients, of course, but the families as well. They couldn't come to the hospital. You said that for some of the parents as well. So in Istanbul, most of the patients didn't want to come to the hospital and postpone their appointments. And again, in Africa, the nurses from Africa told us that the COVID-19 was associated with the stigma, and it wasn't just fear of the disease, but stigma of being a nurse and working in that situation in a hospital with COVID-19. So that increased a lot of distress and anxiety for the nurses as well.
I want to just mention that, if I can break in, that we saw treatment abandonment in pediatrics as well, which was really discouraging. In fact, that study by Gretz et al. Of the 213 institutions across 79 countries, a third of them reported patients abandoning treatment. And I think that really is heartbreaking, because you think about, you have no chance or very little chance with no treatment at all. And the reduction in surgeries, I think people were just really scared. And that was ubiquitous, we found across our authors, that the patients they were reading the news. They knew what was going on, and they were as scared as anyone. And the hospital was maybe no longer seen as a place to get better, but a place that actually was potentially dangerous for you. And has a big psych, that would be a something in the back of their mind.
Yeah, just to say that the areas that we heard that were in conflict, especially in Iraq and in Lebanon as well, with the disasters, not conflict, but with the disaster, that it made things 10 times worse. So in conflict, the patients really got a bad deal. They couldn't, because they couldn't travel, radiotherapy, they didn't have radiotherapy in Mosul and Iraq, and they were unable to travel to Baghdad for radiotherapy. So the conflict scene just, of course, made everything really much worse. So just to round up with the patients, there was a cry for help for the patients. There was a cry for help from the families. And the solutions were very few and far between, but they did find that some of the spiritual care meant a lot to them, especially in Africa and Indonesia, where that is routine nursing care. So there was they were saying more prayers and praying for each other. This is the patients and the nurses, really. So all in all, around the world, and this is just not in low and middle income countries, there was confusion. The confusion moved on to adapting. So we got some tales of adapting, but there was still fear of the adaptation of postponing the treatment and whatever. So we're trying to adapt to the situation, as we still are certainly in the UK. So now we're going to move on really to the ramifications. So there was a fear of the ramifications of COVID-19, and we're going to move on to how the patients felt.
Annie, can you share with us, now that we understand the psychological impact that we heard in the special series about COVID on patients, what was the experience for the nurses and the psychosocial impact on the nurses from COVID in those early days in 2020?
So as you said in your introduction, Julia, there was the nurses are working against this weak infrastructure, really, and against the kind of the social determinants of health. So it could be lack of education, just social housing, not having jobs, and all this. It's difficult, and again the workforce. So they had an enormous burden of work, and we hear in our series about the experiences of the trauma and the confusion, and especially the lack of clarity. So that was early 2020. The lack of clarity of how to help patients and how to treat patients, really. And that all caused huge distress. So there are multiple stressors for the oncology nurses. You mentioned already personal protective equipment, so PPE. So they found that the nurses were telling us that the PPE that they have for giving chemotherapy was being diverted to other areas and to COVID wards, of course. They feared for the nurses feared for their families. They had to work in facilities. Some of them had to work in facilities where COVID-19 patients were being treated, most of them, and some of them had to move from their homes, Julia. So they had to move from their homes, and especially in China, they moved from different cities, didn't they? The government asked them to move, and they did. They had to make up their own minds, but in general, they felt it was a duty. So they hadn't seen their relatives for a long time, and they were just the fear of bringing the virus home, really. So the personal protective equipment was a huge thing for nurses. They felt, I think we've already said about the stigma they felt, about the discrimination they felt, and that was prevalent in the stories we heard from Africa. And it was because of the profession, because a nurse and also the fears of infecting their families and loved ones. But they felt very isolated from normal life, and it was just a huge burden of work. So I'm just going to read something that one of the Turkish nurses said from Istanbul. I was afraid of infecting my daughter and parents who had moved to my house to take care of her, because schools were closed. I had to work in the hospital. At home, I stayed in another room. It's been months that I have not hugged my daughter. And we heard these stories time and time again about the family. So we, just to summarize, nurses experienced increased fatigue. They said they were tired out. We've talked about the anxiety. They weren't sleeping, depression. These are the stories that came through, and burnout. So nurses were leaving as well. They were burned out. And especially in China, they felt a strong sense of burnout. They just worked and worked and worked. But they felt all these factors felt as if they were reducing the quality of care that they could give to their patients and staff. One nurse leader in Brazil was saying how leadership was a huge burden as well, and caused huge stress, because she felt responsible for the protocols and guidelines that you talked about, Julia, and she felt responsible for implementing that, and just responsible for all our nursing workforce. And she said she felt that was a huge stress on her as well. There were disparities across countries in the distress, as we've said. And again, just to summarize, there was and to look for solutions, really. So there was a big call out, or a cry for help again from the nurses. So they were desperate for PPE. So they were asking around. They were asking nurses from high income countries to try and help out there, which in the Global Power of Oncology Nursing organization, we did try and help out with some PPE as well. So they wanted to, it was all to strengthen their capacity. And we talk about resilience a bit, but it's hard to talk about resilience, isn't it, Julia? What do you think about resilience in such a situation?
We started in early days saying how resilient the nurses have been, and the nurses are telling us now to please stop discussing that as often, because they feel that it's making them out to be able to cope with this in a way that maybe they're not coping so well. And it's not looking at the distress that they are having. We are now over, almost coming up to 2 years of these circumstances. We don't have more nurses coming back. We have even less nurses. The nurses are quitting. Some nurses have died of COVID in oncology. And the nurses in some countries, and especially in Africa, have had to switch from 8-hour shifts to 12-hour shifts because they simply don't have enough. And in one hospital in Latin America, they are put out a call for 200 oncology nurses because they just can't find them. And when you think that the training it takes to become a specialized oncology nurse, losing even 1 or 2 from your staff can be really catastrophic for the rest of the team. So I think what we should do is now think about really considering the long-term effects of this continuing stress that you've mentioned, that we heard from the nurses in this issue in mid-2020. But think about now we're at the end of 2021 and they're still in the same circumstances. Things haven't improved dramatically. Certainly vaccines are still difficult in some of the very low resourced countries. And these nurses still go to work every day and they're dealing with immunosuppressed patients. So I think we really have to be sensitive.
I agree, Julia. It was this non-stop care, wasn't it? And by frontline nurses, and we're saying it's remarkable, but it does impact on their mental health, absolutely. And I'm glad you mentioned the colleagues that died, because that came through thick and fast, that they were just knocked and they had to go back on their shifts, but their colleagues beside them were were dying as well. So just awful, really. They didn't like being called heroes. We had that lovely Iranian poem and said, I'm not a hero. I'm a member of this community and I'm a real person and it's my duty to care. So all in all, they put patients first. I mean, I would call them remarkable. And there was a lovely quote from the nurse from Mexico who said, I'm just going to read it again. If I start to think about what's going on, I would crumble. We would all crumble. I need to be okay so that I can contain others who are in a more difficult situation than I. I have to do what I do and more. My duty is to care for patients and nothing else matters. So that's true from the heart, isn't it, Julia? And they go on and all, but clearly that non-stop work affects their mental health.
Annie, I think you're right. I think we had a lot of very poignant from the heart evidence, and I call it, of the oncology nurses' experience and that of their patients as well. I think the takeaways we want people to have when they've read this series is that we also included a brief literature review that we conducted in parallel in the mid-2020 for this issue. We noted the healthcare challenges during the start of the pandemic were shared across the settings, as we've mentioned now. However, there were nuances specific to their patient populations and their nursing resources and care. And I think that's what makes this an interesting read, because it's not just uniform. I think, for example, fear of contracting COVID and bringing it home was pervasive. Telehealth, which you mentioned, was heavily used, but in some countries was not an option at all. But despite nursing shortages, of oncology nurses were shifted to the COVID wards because they're specialized nurses. We know how to deal with infection, that's for sure. Stayed home due to personal health issues or died. And the unknown chaotic expert advice that was changing weekly, even from the global authorities. The nurses in this, the authors of this special issue, chronicled their extraordinary commitment to patients with cancer and their families. I think you have emphasized that as well. So despite the drastic shortages, oncology nurses across the world continue to deliver cancer care and show up for work on extended shifts for no additional pay, especially in countries with restrained resources. So for me, and I think for you feel the same, that as the pandemic grinds on and cancer does not pause, we hold our breath to see what the consequences will be of the ongoing delays, because they continue today, in screenings, diagnoses, surgeries, radiotherapy, and other life-saving cancer treatments. Continued and uninterrupted nursing care for patients with cancer, especially those living in difficult circumstances who we heard about in this series, such as refugees, conflict areas, unhoused, poor, and some patients with concomitant COVID-19, show the global power of care by the largest single healthcare workforce, which is nurses. So I think this hopefully series will take its place as documenting the real-time, on-the-ground experiences from across WHO regions of oncology nurses treating children, treating young adults, treating adults and seniors with cancer, and their experience. And unfortunately, it's not over, but we can see that commitment to duty was something extraordinary and definitely a theme that pervaded throughout the entire series. Thank you, Annie. And I think we could say, let's not forget, and hopefully this is not the new normal, but if people think of this as the new normal today, let's not forget what it was like in 2020, when we didn't know as much as we did, when we didn't have as many vaccines, and that people are still without vaccines. And so we have to salute the nurses who were brave enough in the middle of all that chaos of a new pandemic to sit down and write their experiences and share it with the greater community, the cancer community in this series. We really appreciate their effort, their time, and their energy. And boy, I have a lot of respect for all of them.
I just want to say the same, a huge heartfelt thanks to these nurses, just for carrying on and carrying on with their duty. So I agree. Thank you.
And we appreciate eCancer Medicine giving us the venue, because this is an unusual series, and I think it deserves to see readership. And we hope that the readers take home a good message and appreciate the effort that went into making it, and thank to eCancer Medicine for publishing it.